right, well, here we go. I have a late in the day time, so I hope everybody's sticking with us. Thank you for the movement breaks in between, because I think that helps everybody. I'm so happy to be here, so thank you for the invitation, and it's been a great day so far. So when we start out, if I ask people, how many people, when you think of kids with feeding issues, know somebody that is a picky eater? Raise your hand. Probably almost everybody. And then if I whittled it down to how many people have a child or know a child who maybe eats less than 5 foods, right? And then you can even go even more slim and think of those 5 foods, they have to be the exact same way prepared, the exact same shape, the exact same color, on the right dish. So there's all kinds of things that are impacting feeding, and it's hard to whittle it down into 30 minutes, but I'm going to do my best. So when we think about it, what is the impact not just on the kids, but on the families, right? And I think that seems to be an overarching theme today, which is really nice to see to come later in the day, because many of the things that I'm talking about have been hit upon already, which makes me really happy. So when you think about the kids, you can think about they're hungry, but they don't like what's being offered, and therefore they're not eating. And I think this turns into, they have a behavior problem. They're being difficult. They are refusing. Well, we've mentioned, people have mentioned all kinds of things with the gut, with everything that's going on. There's multiple reasons why they're not eating. It can be also thinking about for the kids how it impacts, they're not eating what their peers are eating. So we talked about the social emotional aspects. We talked about the social inclusion. Mealtime from a cultural perspective and a social perspective is huge, right? We heard it at lunch today how the room where we ate was not quiet, right? If everybody just sat there and didn't say anything, it's not a very fun event. But if you eat and you're really social, what do you do when you're sick? You make food. What do you do when somebody comes over? You have food and drink. And so what do you do with your friends when you're growing up? You go out to eat, you go have a drink, you go do birthday parties. The other thing that's hard for these kids on the spectrum is really thinking about how things look. What are the textures of the food? What's the brand of the food? Especially in the United States, people eat not always the most healthy things, but also very commercial things. So they get used to things in a certain package, in a certain look, and presented a certain way. And then, of course, you have the impact of smell, which from a neurological standpoint, that's a direct connect to your brain. And so that one's really hard to change because it just goes. So if you don't like the smell, there's kind of a hard thing to do with that. When we think about caregivers, that's a whole nother thing. Think of the social isolation that these parents go through. One, they're not able to feed their kid from their perspective, right? I failed as a parent because my child won't eat. And then they feel socially isolated when all they really want is really good nutrition and for their kid to grow. And then, of course, there's the judgment of others. So it's really hard. I'm sure many people have experienced it with their own kids, thinking about, have you heard things like, well, if you just make them eat, they'll do it. Or, I don't let my child down until they clean their plate. Or, well, if you didn't just make what they wanted, then they would eat what you're making. Instead, you do these things. So there's a lot of judgment when it comes to feeding and eating, and that can really impact. And then when you come within the family dynamics, sometimes the parents are not on the same page. One is very strict, one is very lenient. Then the kid goes to therapy, the therapist is lenient, the behavior specialist is a little more strict. And so that can impact and send mixed messages to both the family, or the parents and the child. Now take a look at this slide just for a second. I'm certainly not going through all of these. If you think about the documented interventions for autism, here I've listed 21. How is anybody supposed to decide what approach is best? And I think we've heard it this morning that it should be individualized and really looking at what is the best fit for the child and the family. As an occupational therapist, of course, I'm looking at what are my choices to use in therapy. And then even then, there's 15 approaches that are commonly used to treat autism within the scope of occupational therapy. And some of them might be a stretch, but every one of these listed, I can probably work in feeding with this. So there's a lot of variety, but there's also a lot of room to make it individualized to the client. So when you think about the evidence, clearly there's evidence documented that kids on the autism spectrum have sensory processing disorders. And it ranges, depending on what study you're looking at, from 69 to 95%. And then some evidence, there's evidence that some of the symptoms get better, and there's some that say the symptoms get worse. So then when you think about it, but overall autism has a higher prevalence of sensory processing issues than other diagnostic categories. Now when you look in the literature and you look at feeding, it's reported that anywhere from 46 to 89% of these kids with autism have some sort of feeding issue. And then the research differs because people are defining things differently, whether it's picky eating, feeding aversion, sensory-based feeding problems, food refusal. So again, not all studies are calling the things the same thing, so it's really hard to pinpoint who's calling it what. And then we heard this morning about other comorbid conditions, which is so prevalent with feeding. And Ms. Gupta mentioned some, and is it Dr. Moshe? I forget. Mentioned, but the anxiety and the neophobia, anxiety is key because if you're anxious when you're going to have a plate of food in front of you, and if you're anxious, you're going to have those neurochemicals released and you're in fight or flight. And so what happens? What happens when you're nervous? Do you feel like eating? Right? So if anybody's not a comfortable public speaker and you're like, oh, I really can't eat lunch because I have to speak this afternoon. Fortunately, that's not me, but I was happy to have lunch. But anxiety can really make a difference. So the kids might be saying, I'm not hungry. No, you need to eat. I don't want it. I'm not hungry. They're probably telling the truth. And if they're not verbal, what are some things that you see to tell you that they're not wanting what's in front of them? You might see some hitting, some kicking, some trying to get up from the table. So all of these things, again, are telling you something. So to try and narrow it down for today, I really wanted to look at some things to consider, and I'm going to talk about 4 things, all really quickly, but if you think about looking at medical stability, then we're going to look at some readiness, the readiness of the child as well as the readiness of the parent. Thinking about that individualized approach, which has been emphasized today, which again makes me really happy because I think with all things feeding and your approach to feeding is not a very good cookie cutter, right? There's no good recipe that if you do this many times, it's going to get better. But then also choosing it with intent, meaning what works for your family, right? Maybe the ABA approach is a very good approach for your family, but maybe it's not because you can't keep to that structure. So then thinking also, lastly, but I think somewhat most importantly, is that trust with the intervention, the trust in the therapeutic alliance. And for me as an OT, that's the crux of my intervention right there. If I could probably spend 2 days talking just on the therapeutic use of self and the therapeutic alliance within the realm of feeding and eating. So as we mentioned, not everything is sensory, and I think that's really important to remember. Not everything is a behavior, right? So Tim Bowie talks about how at least 50% of the kids have some sort of gut issue, and some were mentioned this morning. Some things to think about are reflux, motility issues, constipation. Also kind of, I'm going to say common, but I think it's commonly missed, is eosinophilic esophagitis, which is allergy and an immune issue where there's eosinophils in your esophagus, but it presents so much like sensory-based feeding. I've had a couple kids really stump me, and finally I've gotten the parents to get an endoscopy, and lo and behold, with the endoscopy and biopsy, they've got, it's shortened as EOE. And once they eliminate some of these foods from their diet, you see this drastic change. Allergies were mentioned this morning, and then there's trauma around feeding. When I talk about trauma, it can be multiple things. It could be somebody with poor dentition, so every time they eat, they have pain. It could be they had a choking episode, and so then they're afraid to eat. It could be they got sick and vomited. Trauma can also be because the parent is wanting them to eat, there's a little bit of force feeding. So when I say force feeding, I don't mean it comes from a ill intent. It's I need my child to eat, but that force feeding can cause trauma and then cause difficulties in coming to the table, accepting and trying new things. So what can we do? What are some suggestions? Of course, know your team. And I was really great this morning with the whole team of professionals. I think it's so important. Connections with some of the psychiatrists in my area, because I think with a low dose of anti-anxiety medication, I've seen kids do really well in progressing and feeding. The tonsils and adenoids are another one. Once they've come out, I've seen improvements in feeding and eating. So know who you need to refer to, but especially GI. If you're a therapist and working in feeding, the GI specialist should be your best friend and have really open communications to know what's working and what's not working. So when we think about how can we be ready, who's ready for feeding? How do we know? What are some things that we can look for? What are some signs? In thinking about this, the social emotional regulation, and that was highlighted this morning. These kids need to be able to be comfortable around food. If they're not even comfortable, coming to the table can be a battle, right? And it's no easy feat. And if you have multiple kids that you're trying to care for, you're trying to make meals, you have homework, all of these things, some of my families report that they spend at least 2.5 hours per meal. So when you add that up on top of everything else that you have as responsibilities as a parent, your day can get really miserable really quick because you're spending 6 to 10 hours just trying to get your kid to eat. So when are you supposed to do anything else? So with a child, also we heard about apraxia, childhood apraxia, and motor planning. We can look at oral praxis. Do they have the skills and ability to manage the food that's in their mouth? Is that why there's some selectivity in what they're choosing to eat? One thing to think about is, do they have at least a preferred food? If they have a preferred food and you're the one doing the assessment, please have the family bring in. I always ask them, can you bring in one thing that they will eat, hands down, any day, any time, any environment, right? Because if they're coming to see me in a clinic, already I'm a new person, it's a new environment, that's going to add some stressors. So I want something that I know they're going to eat frequently. And then, are they showing interest? Does the child at least have an interest? Maybe they like watching what you're eating. Maybe they're watching their peers. Maybe they're kind of looking when you're making food. So take those interests and build upon those strengths, have them help you a little bit, have them prep some things with you. It's very surprising how much a 2- and 3-year-old can do in the realm of like helping cook. And then thinking about initiating exploration. Are they able to pick up a food? Are they able to give you a bite? Are they able to give somebody else a bite? Are they pretending with some of the food and initiating some of that exploration? So with some of the older kids that we see, sometimes we'll use that cognitive approach, and we call them food scientists, right? And there's all kinds of things you can do to be the food scientist and discover what's going on and make it a little bit fun. When you think about the parents' readiness, again, what is their expectation? Is their expectation that they're coming to see me, the OT, and in like 2 or 3 sessions their kid's going to be eating? If it is, I need to do a really good job explaining that it's going to take a little longer than 2 or 3 sessions, I can almost guarantee. But so help them understand what is their top priority, where is their biggest struggle around mealtime, and help them build those expectations to be a little balanced in reality, meaning you don't want to take away their hope, and you're not going to say, oh, this is going to take so long, but you want to say every child's different, and then you can tell them along the way the really positive things that are changing, even though they might not still be eating the food. Do they have the resources? Are they hooked into the specialist? Have they been to a GI? Are they a family that's had a pediatrician that said, oh, they'll outgrow it, don't worry? I have had so many families that have told their pediatrician since that transition time to going to solid food, so like anywhere from 7 to 9 months, that the child's been struggling with difficulties, and finally they made their way to me around age 3. So what does that tell me right away? For 2.5 years, this family has been struggling, right? And for 2.5 years, they've been asking for help, but they've been told, oh, they'll outgrow it. And meanwhile, the kid's now down to 3 foods, right? So that makes it really challenging, but it also gives you, as the interventionist, perspective on where they are, where their stress level is, and where maybe you can help first. which leads to the third bullet point of the stress level, right? The parent stress, I think we therapists, I'm gonna just call out the OTs, we sometimes forget about that, and we think that they're problem parents, right? Oh, this parent is so high maintenance. That's not it. We have to take a step back and think, this parent is so stressed, how can I help them? And you can help by listening to what their issue is, where they're struggling, how long they've been struggling, and what's most important for them to make their life and mealtime strategies a little bit easier. When we think about the child, then in how we can facilitate that readiness, again, this seems to be the overarching theme today, is use their strengths, right? I think it was said during the panel discussion that these tests, the tests that we use, say what they can't do, and I'd like to, it's a little prideful, but in OT, we're looking at the child's strengths, and we tend to do that, and I've been at several IEP meetings where it's like, why can this profession, I will leave it blank, not tell me anything my child can do, but OT, their report is filled with what they can do. And so remember to help the parents see what is the good part of what they're doing and those itty-bitty baby steps. And I talk about the baby steps all the time. There's nothing more frustrating for me than coming out of a session being like, oh my gosh, it was so great. Today they were able to, like I spilled something kind of on purpose, and they just reach for it automatically and help me clean it up. And I'm so excited. And then they're like, but they didn't eat it? And I'm like, no, but they did this and this and this, but they didn't eat it. Okay, let's go. And I'm like, right? Like that's really disheartening. And if I feel that, what do you think the child feels? Right? So helping the parents see those little things. And it doesn't mean that they can't be disappointed that the child didn't eat something, but they can be happy that there were some really positive steps towards engaging with the food, towards coming to the table, participating, initiating something. So those things are really important. Help the child by having some general expectations. Help them by changing only one thing at a time. Don't just have all this non-preferred food and say, these are the things we're going to try. And of course, in therapy, a play-based approach is huge. We saw it with Tracy's presentation with the speech. I mean, look how much you can get with play. That doesn't mean the whole mealtime is turned into a play session. That's not it. But you can have some snack times and some play-based activities with food that will help support that. And then again, set them up to succeed. If I put 5 things that are non-preferred and 2 little crackers of their favorite thing, how do you think the mealtime's going to go if that's all they get is, they already see from the beginning they only have 2 of their favorite bites. So again, have a little bit of balance and set the scene for success. For the parents, again, helping them with expectation, have a shared decision-making process. Parents often see therapists and other team members as in a position of authority, but you wanna have that shared decision-making process. I can always pick therapeutic goals, but if it's not important to the family, then it's not a good goal, right? Like, I might think they want to do that, this child should be doing something, but if that's not a good fit and that's not an emphasis, I'm also not going to get the carryover from the family if it's something that's not meaningful for them. Set the family up to succeed as well. Give them those positive feedbacks like, oh, I noticed when you were giving them the bite, you waited because they turned away, that you didn't just chase them around with the spoon. Those are really affirming things to hear when they're doing something well. Can you make sure you're helping them link to resources, other specialists that they might not have found yet? Or is there a good family match? There's research that supports peer-to-peer and family-to-family is a very good, effective intervention, and it doesn't just turn into a complaint session, but the families see quickly that they're not the only ones struggling with this issue. And then acknowledge the difficulties. I think sometimes we forget to acknowledge with the families, like, wow, when do you have time to do anything else? You're spending 8 hours a day trying to get your kid to eat, right? And we know from working, if we work a normal day and have to come home and spend 3 hours trying to get through one mealtime, that's probably going to be a little bit stressful. So help them navigate that feeling of being judged, that feeling of blaming themselves. Because, I would say 9.999, it is not the family's fault, right? They didn't cause it, they're just trying to help facilitate a change. So when you think about sensory, then there's so much to consider, right? So I've kind of narrowed it down to 4 points, which is really short. But thinking about tactile, we can think right away about tactile defensiveness, over-responsivity to tactile. If I asked any of you, is there a texture that you don't like, right? Probably you could think of one. For me, it's oatmeal. I don't like oatmeal. If I talk about oatmeal, I'll have autonomic responses. My eyes will start to water. I'll start to salivate. And yeah, it is not my favorite by any means. So those are some things that you have to think about. You also can think about proprioception, that information your joints and muscles get. Proprioception can be thought of in a couple different ways. One, proprioception, the kids are going to use that as a modulator. So these might be your kids that are pushing back in the chair. They might be looking for more information. And then proprioception in the realm of, if you have inadequate processing of proprioception, you're going to have likely poor motor planning and poor tactile discrimination. And we'll talk in the next few slides about some examples of those. And then you don't usually think about the vestibular system as impacting feeding, but it can in the realm of arousal, attention, and then also your postural stability. And we'll talk in a little bit even about gravitational insecurity and how that can impact your mealtime. And environment is huge too. If it's really loud, I don't know if anybody noticed in the beginning of the presentation right after lunch, people were still settling in. And for some people who are really sensitive, me, I kept turning around because I'm like, people, it's time to be quiet, right? The room was still a chatter, which is good because everybody was socializing at lunch, but it was bad because we were trying to stay on schedule, right? But the environment can impact how somebody's participating in a meal, and it can impact how they interact with their peers and with the setup of the mealtime. So bringing sensory modulation and then perception and sensory motor into the mealtime. When it's a modulation issue, you'll see the tactile defensiveness, gravitational insecurity, meaning being fearful of being up off the ground. So if you think of kids in a high chair or being moved through space to be put into a chair, that can be enough to set them off and dysregulate them for the rest of the meal. If you think about under-responsiveness to vestibular, these are the kids that are needing a lot of movement. So they might be your really wiggly kids, your kids that are getting up and down, and as a family, that's going to make you a little bit crazy. When you think of perception and sensory motor, that we're thinking about tactile discrimination, so tool use with utensils, the ability to feel things in your mouth. Inadequate vestibular postural responses, are they slouching? Are they looking for more input so that they know where their body is? Are they leaning and going down into the chairs? And then I mentioned inadequate proprioceptive processing, pushing back in the chairs, stomping, pushing on things, and then oral praxis or poor motor planning. So the literature really points out very well the different behavior patterns that we see in kids with autism. On the left are typical behavior patterns that have been shown in the literature, and then if you look to the right, we can think of some examples on how that might express itself in a mealtime. So if you think of affective symptoms, you might think of some combative things at the mealtime, throwing food, dropping things, pushing it off the table. When you think about increased rigidity, the kids only eat a certain food, a certain color, presented in a certain way. Increased repetitive behaviors could be representation of anxiety or some GI issues and being uncomfortable or in pain. Social impairments, thinking about that social reciprocity during mealtime, the engagement that you typically see with babies when they're eating, but you might see no eye contact, turning away, and no joy in sharing a meal. When you think about adaptive behaviors, thinking about, again, tool use, and then attention and focus, the kids not wanting to stay at the table or being wiggly. The next few slides I'm going to go through rather quickly. I have a video at the end that I want to save some time for. So the over-responsive pattern is the most familiar sensory pattern and the most seen in research. So thinking about tactile, that's the easiest to see, but also auditory, and I just mentioned that on how that can impact yourself in the environment around mealtime. So thinking about that, you're going to if it's overreactive, you want to think about how smell, taste, touch, and the noisy environment might be impacting them. And it can be really unsettling and make for an unpleasant mealtime. Thinking about proprioception, again, if you don't have good processing, you might see some overstuffing in the mouth. They need more input. So tactile discrimination and proprioception are impacted. But also, if you have poor motor planning, sometimes that people misread that as tactile defensiveness, because the food goes in and then what do? It comes right out, but it's only because they can't figure out what to do with it and how to move it to be able to chew it and move it back to swallow it. So I think this is what I just talked about, so that's good. Thinking about tactile discrimination also, they might drool or gag or bite their cheek before they swallow. They might not notice that they're doing these things. And again, like I mentioned, they might overstuff or prefer some crunchy foods. Vestibular, I think I gave some examples about that. One thing to think about is when there's an over-responsivity to vestibular, so not only gravitational insecurity can be a factor, but we've had a couple kids that I've consulted and they're like, they'll drink out of a straw, but I can't get them to drink out of an open cup. But when you think about taking a drink, what do you have to do with your head? What do? You have the cup and your head goes back, right? So even that little bit of going backwards through space was enough for them to be like, I'm not drinking out of that cup. But as soon as I gave them a straw, they drank out of the cup. So it's not a matter of, I don't know what to do here. It's a matter of, I need to work on the vestibular system to work on the cup drinking. Talked a lot about environmental considerations, just thinking about what they need. Calm, quiet, a little bit of noise, what kind of music might be helpful. The position, are they sitting facing a window? Is that too distracting? Do they need not to have so many distractions? And then think about visual on the table. Is it overwhelming to have so much in front of them, especially if it's non-preferred things? Again, thinking about what else can you do, thinking about how to let them know when mealtime's going to be done, the environment, like, oh, look, we're almost done. Look, we just have a little bit to finish up. Or even working towards those kids that have a dependency on video or technology during mealtime, you're going to really want to work towards weaning that away. Okay, so then I have 3 minutes left, and I did better on my trial run. But thinking about the Therapeutic Alliance, it's so important to have that and to have them know what to do and have them feel safe, both emotionally and physically. So I'm going to go past this one and hit this one, that you, whoever's working with them, that's the you. Could be the parent, could be the therapist. You're responsible for keeping that emotional safety during your session to help them know what their expectation is and know that it's okay. You can't always just hop right into feeding as soon as they come into your session. So there's all different sorts of things that you can do, but really focusing on that attunement, that relationship-based approach, so that you have that trust and interaction before you're asking them and pushing things upon them. Okay, and then use yourself as a co-regulator. If I am all anxious and I'm worried about what they're going to do and I'm talking like this, come on, we got to eat, they're going to feel that, right? So you have to kind of calm yourself down. So I'm going to run about 2 minutes over. I'm just going to forewarn you because I want to make sure I get to the video, which is on the next slide. So it's really almost done. But this is Sean, and you can see here, using a play-based approach here, but I have a video clip, and prior to what you've seen, we've already done some sensory motor work. We've done some heavy work, some pushing and pulling. At the time of this video, I think he was 3, maybe 4, but prior to coming to me, he had a year of OT where the OT was force feeding him. And the stories that this mom tells me saddens me. And so they are very traumatized, both the mom and the son. I can't have a spoon out, so we're going to be working with this little alligator. And in the little cup is some freeze-dried yogurt. They're little yogurt melts, along with a little bit of pixie stick, which is like a sugary powder, and then you'll see me add some water. But I want you to look for that therapeutic use of self between myself and Sean, and then the mom's in the background, and then also how I keep him going. When things are too much, you'll see him And then when things are going well, you'll see him, but you'll notice I'm not forcing him. We're not at the table. I'm not doing hand over hand. I'm not telling him what to do. And I think those are all keys that tie in what we just got to talk about. Okay. If you can play the video, that'd be great.
What do you think?
Trying to get a little bit of proprioception. He's like, no.
Okay. It's like,
not gonna do it.
Num, 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 num.
I'm giving him time. I'm not telling him to do it again.
Oh, is he going to get more? Use this hand. Use that hand to open. Can I have you help?
I was trying to get him to use his other hand, but he was really leaning on it.
Sometimes I just have to take advantage. Oh, which one?
I wonder if you did that stuff.
Huh?
You know,
Which one?
If he's that excited, he would pick up wet.
I was wondering if you poured the water in there and just got it a little.
Push him over his.
so
You
that
got
was,
that little cup.
this is our little push, because now I'm really changing the dynamics of what he's reaching into. And you can see him. He's like,
It got wet.
but I didn't trick him. I didn't hide it. I showed him what I was doing.
So that's going to be the demise of the yogurt. What do you think? What do you think?
I know.
Did you see the camera?
Old-fashioned thing called a video camera.
I know, I had a phone. Good, Sean.
So he's getting his fingers wet, and then now it's sticky.
Got some on his lips.
And then he got some here.
Maybe the alligator.
Oh, the alligator did. I'm proud of you. Nice. That's a big deal. I know, you did it.
You can see him take pride in what he did.
Num, num, yummy, the alligator says. Yum, yum, more please. Yum, yum. Uh-oh, one came out.
2 came out.
Oh, 2 came out.
You can see him start to move his mouth as he's doing it. So this was just a 2-minute, 36-second clip of probably close to 18 minutes of us engaging in this one way or the other. And I am happy to say at the end, we got a spoon out, and he initiated feeding Snoopy, which is in the background. That's his little transition toy. And then he brought the spoon to his mouth. And I don't know who was happier, Mom or me, because I was like, because none of us asked him to. And it was like, I was never so grateful I had the camera rolling. But I hope that gave you a little insight and really to think about our kids and knowing how we can support them the best to bring out the best in them and to help the families along. So thank you for having me.